Pediatric Surgery, presented by Dr. Srikumar Pillai, Associate Professor of Surgery and Director of Pediatric Surgery at Rush University. Please welcome Dr. Pillai.
Well, thanks for coming so early to hear a talk on pediatric surgery. We didn't plan on starting with the youngest patients first on the course, but it's a good start. I'll try to go over as much as I can with pediatric surgery. It's a big topic, but I'm going to focus a lot on the gastrointestinal problems that we're going to see, and a lot of the questions that are going to be on the research as well as the board exams. We'll try to touch on the majority of those topics. They always switch them on me, but just be patient and we'll get through it all. Disclosures, there's nothing to disclose at this point. The lecture module, so as you can see, there's a large, varied number of topics. I'll try to give you some hints how to remember some of these things and some shortcuts, and we'll start. And we're going to start with the beginning of the GI tract and end with the end of the GI tract. So, esophageal atresia and tracheoesophageal fistula. So first question, what type of esophageal atresia is most likely to be considered long gap atresia? Type A, type B, type C, type D, or type E? All right, so we got a little bit of a split here, but actually the type A, 33%, so about a third of you got this one right. I'll tell you a little bit of how to remember it and why, if you get this question, what to look for. First of all, with esophageal atresias, everybody talks about vactral anomalies. These type of congenital anomalies come in sequence with other ones. So with the T fistulas, imperforate anuses, and other things we're going to talk about, you'll see some vertebral anomalies. Cardiac's a very important one. You'll see about 35% of these patients will have cardiac anomalies. Renal anomalies about 24, and anal anomalies about 24. So those three, probably anal, cardiac, and renal, the three most common that we see. And then the vactral, so just easy mnemonic is vertebral, anal, cardiac, tracheoesophageal, renal, and limb. Clinical presentations for this, initially in the newborn period. A lot of times these can be picked up prenatally if there's polyhydramnios, especially if it's a type A, because there's there's basically a high-grade blockage in the GI tract. So they'll have excessive, they'll have polyhydramnios prenatally. After birth, you'll see excessive salivation. You may see some vomiting, choking or respiratory distress, especially with feeds. And pneumonias occur in one particular type, that type E is where the pneumonias are going to be occurring. I'm sorry, not type E. Yeah, type E, you're right, type E. So this is the pictures of the different types of atresias. Now, the pictures are arranged in the order of percentages. However, the names underneath are the actual types of fistulas. So we're going to go by the letters, and I'll tell you the quick way of remembering these. If it's a pure atresia with no fistula, it's a type A. So that's the very first one, is just esophageal atresia, there is no fistula. If it's a fistula with no atresia, it's type E. So the very end one, you see the fistula, but the esophagus is in continuity. So if it's pure fistula, it's a type E. If it's pure atresia, it's a type A. And then you go, and you look at number B at the very end, it's a proximal fistula. So the proximal pouch is the fistula. If you go to number C, it's the distal one that's the fistula. And if you go to D, it's a proximal and distal. So that's an easy way to thinking about it. So you go from no fistula, a proximal fistula, a distal fistula, two fistulas, and no atresia. When you talk about long gaps, like we talked in the first question, biggest thing about the long gap is that if the distal esophagus is tethered to the trachea, as the trachea grows, that distal esophagus will actually gain length. If you don't have a attachment to the distal esophagus, then the proximal esophagus will get down to about T2 in most of these situations, but the distal esophageal placement is going to be based on whether it's tethered or not. So when you look at an A-type fistula, which makes up about 8% of these cases, there is no tethering of that distal esophagus. So that's going to be more of a long gap type fistula. Whereas the most common type that we see, the C-type fistula, which is 85% of the cases, that's actually tethered. So the chance that that's going to be a long gap fistula is much less. The other one that could be a long gap fistula in these things is a B. B and D are both less than 1% of the cases we see. But if you look at the B, it's a proximal fistula. So again, the distal esophagus is not attached or is not in communication with the trachea. So there's no real growth in that distal fistula. Treatments for this, really you want to control the fistula if there's a fistula because it's in continuity with the GI tract. The stomach can reflux up. It goes directly into the lungs, and the patients develop pneumonias, aspirations, and have respiratory distress. So the first thing you want to do is control the fistula. Some cases, you can put in a gastrostomy. We do this only in severe cases when they're premature babies because you're not really controlling the fistula at this point yet. You're trying to decompress the stomach so that the two reasons. One is that you don't want stomach dilatation can cause respiratory distress. And secondly, is as the stomach gets dilated, the chance that the child's going to reflux gastric contents back into the lungs is much higher. So we'll put a gastrostomy tube in severe cases. Fistula ligation alone, we do this in premature babies or smaller babies, or in the patients where we can't get the two ends together, we'll ligate the fistula. Once you ligate the fistula, that's probably the most urgent part of the case, because once you take away that communication, you can always put a G tube in, you can always treat, you can always feed the baby, and you can take your time and do the repair. So you can ligate the fistula alone, or you can do the combination. You can ligate the fistula and do the esophagostomy. That is the, well, that's what we try to do in most of these cases if we can. So you'll ligate the fistula and you'll bring the two ends of the esophagus together. It's an interrupted anastomosis. It's a single layer anastomosis, and you can do this either thoracoscopically or you can do this open. In very severe cases where you can't control, some people have described division of the esophagus at the G junction. That's an extremely rare circumstance. So either fistula ligation alone or the combination procedure, fistula ligation plus esophagostomy, are the two most common things that we can do. Post-op complications, leaks are very common. About 15% of the patients can get leaks. These leaks are usually self-contained. When we go in for the operation, we try to do what they call a retropleural approach. So we try to tease off the pleura and go retropleural, and then we do our repair retropleurally. So if you have a leak, it's not normally in the chest, it's in the retropleural space. Usually these leaks will resolve on their own. They don't require another operation. And we just basically watch. For these to close off. We usually leave chest tubes in at the end of the case. So as long as the chest tube is draining and the child is doing well, we just give it time. Recurrent fistulas in about 10% of the cases. You can get this if the suture lines are close together. If you have to go back in and reoperate on these recurrent fistulas, you have to do some sort of a patch or some sort of a covering between the tracheal repair and the esophageal repair so that the recurrence rates or the recurrence rates of a fistula will be much lower. If you don't have that, then you'll get another recurrent fistula, of course. Strictures, about 40% of these patients will develop strictures. These are easily dilated in most cases. Depending on what type of stricture you're seeing, if it's a reflux stricture, and all these patients have reflux, these strictures will be persistent and will require continued dilatation. Some of these patients may require a Nissen fundoplication if it's severe enough and if the patients can't feed or tolerate enteral feeding. The reflux, all these patients have reflux. We always position them in the head-up position. There's we use either H2 blockers, proton pump inhibitors. Cisapride used to be used. We use erythromycin if we need to now. Usually between the H2 blockers and positioning, they usually resolve by the time the child's about 1 year of age. So we usually monitor this until about that age. Tracheomalacia, all these patients have tracheomalacia due to the deformity. This actually resolves by the age of 2. In very severe cases of tracheomalacia where they're having severe respiratory distress, sometimes we can do an aortopexy and tack the aorta and the trachea, or tack the trachea to the aorta to prevent that from actually causing compression. Now moving down to the stomach, most common thing we see here is the pyloric stenosis. This is a very popular question on every exam, including the in-services, I guess. Incidents, very common, 1 in 300 to 1 in 500 live births. Males get hit with this more than the females, and it's usually Caucasians that get this other than other races. No one really knows the real true etiology of this. Some people, I think it's familial, and there is some genetic component to this. Some people also think it's postnatal work hypertrophy. They've seen this occur with patients on erythromycin, where there's increased gastric motility, and that causes gastric hypertrophy or muscle hypertrophy. Clinical presentation, usually about 3 weeks. Somewhere between that 3 to 6 week period is when we see most of these cases. It's very rare we see it beyond that. The biggest presentation factor is it's lots of emesis, projectile emesis, but non-bilious emesis. So if there's no bile in this, it's just whatever your stomach contents are. In very severe cases, we see weight loss and severe dehydration. This is rare to see now because the minute anybody comes into the ER nowadays, there's some sort of diagnostic test they do for everyone, so no one gets a misdiagnosis on this. The pylorus, basically you can see this here. This is the pylorus, and this is the hypertrophy of the muscle between this. So it's basically a gastric outlet obstruction is what you're dealing with. Used to be, back in the day, you could palpate the olive. Most people nowadays, because we're picking it up so early and because everyone's lost practice in palpating the olive, no one feels it anymore. And so that's a lost art. Ultrasound is now the proven test of choice for this. Any child that vomits now immediately goes and gets an ultrasound. Reading the ultrasound is another issue, but they all get the ultrasound. What you're looking for muscle, if you're looking at the entire radius of the muscle, it's about 7 millimeters. So each muscle, each side of that should be about 3 to 4 millimeters, 3.5 to 4 millimeters. And the channel length of the pylorus should be about at least 14 millimeters. If they match any of those criteria, then it can be called pyloric stenosis. In some cases, if the ultrasound is non-specific and the child is having prolonged symptoms, we'll do the upper GI, or if we have done a pyloromyotomy and the child has continued symptoms, we'll do the upper GI just to see if there's, as a post-op test. The upper GI is rarely used nowadays as a primary test. This is a picture of the ultrasound, and this is your two muscles. There are two halves of the muscle. Each of these should be about 3.5 to 4 millimeters is about the width of this, or the thickness, and then the length of the pyloric channel from this is the length of the pyloric channel, and that should be at least 14. The other things you can look for in the ultrasound is you can look for no fluid going through the pylorus. So as they're watching the stomach, they can see the stomach contents just moving back and forth, but no projection through that pylorus muscle and no fluid going through into the duodenum. This is the upper GI looking at this, and this is what they call that string sign, or the train track, this thin amount of barium that's coming through. And if you can see this dark area here, and this dark area here is the actual muscle that's actually hypertrophied on the upper GI. So this is not an emergent operation anymore, and it's not even an urgent operation for us anymore. The biggest problem with these kids is we really look for the resuscitation effects. So if these kids come in under-resuscitated, they're at an extremely high risk to undergo general anesthesia. So our biggest concern with these kids is really to correct the electrolyte imbalance, especially the bicarb. You want to get the bicarb below 30. They have a hypochloremic, hypokalemic metabolic alkalosis or contraction alkalosis. And this is what you have to correct. You correct it. It could take, in some of the severe cases, we've waited up to a week, 10 days to get these corrected before we could do an operation on these kids. Treatment has not changed in over 100 years. It's a pyloromyotomy. We just split that muscle. The only thing that's changed over the last 100 years is how you approach the pylorus. It used to be you did a right upper quadrant incision. Some surgeons still do that. It's a fairly safe way of doing it. Next move was to do a supraumbilical omega incision and get in and do that open. And the last way that most of us are doing now, that's been much more frequent, is doing a laparoscopic pyloromyotomy. So that's what we do now. But any of those three procedures, you end up with the same result. You just split the pyloric muscle. The things to remember about pyloric stenosis: when you split the muscle, if you get into the mucosa, people have different ways of attacking this. I don't know if the boards have changed on that. It used to be that you would close that area, flip it to a different area of the pylorus, and do the incision in a different area. A lot of times, if the pyloromyotomy is relatively complete, the area where you get the area where you actually get your perforation is going to be on the duodenal side when you do your split. So as you're splitting the pylorus, if you're getting to the duodenal side, the muscle is much thinner there, and the mucosa is much closer to where you're splitting. So that's where you're going to get your perforation. Recurrence on pyloric stenosis is due to the fact that we didn't go high enough on the stomach side. So if you don't split high enough on the stomach, you get the recurrence. Similar to when you talk about achalasias. If you don't go far enough down in the stomach, you can get a recurrence in the achalasia. If you go too far up on the esophagus, you can get a perforation of the esophagus. So similar type of situation. So when we get the perforations, what we do now currently is we just close that perforation. If it's basically the pyloromyotomy is pretty much done and we got it at the very end, we'll just close that. We'll just close that one area. We'll wait a little bit before we feed the kids, but that's all we need to do now. We don't usually flip and try to do a pyloric on the other side anymore. But I don't know if that's changed or not. That's what our practice is. Intestinal atresias and stenoses is the next topic. Pyloric atresia, we don't have to talk about. It's extremely rare. Duodenal and jejunal ileal atresias are probably the most common things, and that's what we're going to focus on. Colonic atresia is also pretty rare. We'll talk about duodenal first. For the duodenal atresias, it's a duodenal obstruction. So it's a proximal obstruction. This is something that can be diagnosed prenatally. There's multiple different ways this can occur. You can have a true atresia. You can have a stenosis or narrowing there. You can have a diaphragm or a windsock type of anomaly where there's a diaphragm within the lumen. You can have an annular pancreas where the pancreas comes around the duodenum and basically causes the obstruction. The things to remember: trisomy 21 is up to 40% of these patients can have trisomy 21. Bilious emesis, 80% are going to be post-ampullary, so 80% will have the bilious emesis. However, 20% may not have bilious emesis. The abdomen is scaphoid, and this is another thing in pediatric surgery that, since we see, so when you look at obstructions in pediatric surgery, anything before the ligament of Treitz, so duodenal atresias, malrotations, these type of problems, you're not going to have a lot of distension. You'll have a lot of bilious emesis, but you will not have distension. They'll all have scaphoid abdomens. If you have anything beyond that point, like jejunal ileal atresias, Hirschsprung's disease, imperforate anuses, anything beyond that, you may have bilious emesis, but you will have distension because the air gets down much more distal. So any proximal obstruction is just going to be they don't look obstructed per se when you look at them on a physical examination. Plain radiographs on duodenal atresia is the double bubble sign. This is the most common and the easiest way of diagnosing this. You don't see any distal gas. If you're seeing distal gas and not just two bubbles, you're a little bit more concerned that this may not be a duodenal atresia, it may be a malrotation. It's hard to tell that just from your studies unless you truly only see two large gas pockets. upper GIs on these cases. So if a complete obstruction, we rarely need to get the upper GI. If there's concern about malrotation, you'll get it. What the difference that you see in this is that when you see a duodenal atresia, it's a nice round bulbous end of the duodenum. If you see a malrotation with an obstruction, you're going to see more of a bird's beak, or more of a narrowed end. So it's more of that kind of an end to the upper GI. Sometimes you can see a little bit of gas if there's an annular pancreas. Some of the gas can go through the pancreatic ducts and come back out. So you can see a little bit of gas there. So that makes it a little bit more confusing. This is a picture of a double bubble, big stomach, and big duodenal bulb. A lot of times these kids will come in with NG tubes and be decompressed, and you don't see anything on the radiograph. So we'll actually inject air through the NG tube to create that double bubble look to get the x-ray. So we'll actually look at that way. And if, like I said, if there's any question, if you see any distal gas, or if there's any concern, the upper GI is the way to go. Treatment, it's a duodenostomy if you can do it, if you can get the two ends together. Sometimes in the case of an annular pancreas, you may not be able to get the two ends of the duodenum together. There may be a fairly tight type of area, so you can do a duodenojejunectomy at this point. The biggest thing to remember is for the annular pancreas, you never divide that pancreas, so you never split the pancreas. You always divert around the pancreas. Jejunal atresias. These are probably the most common atresias we see. Atresias make up about 95% of this, and then stenosis is rare. It's about 5%. Fairly common, down to about 1 in 300 live births, evenly distributed among the small bowel. Clinical presentations is bilious emesis, progressive abdominal distension. So this is going to be distal to that ligament of Treitz. You're going to get some abdominal distension, failure to pass meconium in about 70% of patients, which also means 30% of the patients you can still have meconium. So it means that the atresias may have formed after the meconium or later in the development, so after meconium has passed through it. Differential diagnosis, any distal bowel obstruction or any reason for distal bowel obstruction would be a differential. So Hirschsprung's disease, some of the diabetic mothers, the kids will have small left colons. Colonic atresia, like I said, is very rare. Meconium ileus from cystic fibrosis can also show the same pathway of having, basically you're looking at a child with abdominal distension, obstruction, and when you look at the plain films, you'll see some dilated loops. So any of these things can look like that. Diagnosis, lots of bile. Basically, it's obstruction, and you're going to have a lot of bilious emesis. There's no flow of that through this intestine. Plain radiographs will show you pretty large dilated loops of bowel. You'll see some stacking. You may or may not see, if it's a meconium ileus, you may not see it. If you do a lateral film, you won't see air fluid levels, and you won't see those type of things in the meconium ileus type problems. But if you see this in the jejunal ileoatresias and other obstructions, you'll see the air fluid levels on those. If you did a barium enema, you may see a very small unused colon. The caliber is going to be very small. The whole entire colon will also be affected. It won't be. So if you're concerned about the diabetic mom and the small left colon syndrome, the right side of the colon should be relatively normal. If it's jejunal ileoatresia, then the entire colon will be looking pretty small. The types of atresias, I just did it with pictures here. This is a type 1. What you remember about type 1 is that basically it looks like the bowel is in continuity. So the bowel looks like it's in continuity. There's no mesenteric defects you can see, and everything looks like it's, but you can tell that there's a huge caliber change in the intestine. Type 2 is you can actually see a cord-like change in the bowel. So you actually see the atresia or the atretic segments here in the type 2. There's type 3A and type 3B. Type 3A is where you see, basically you can see a complete division of the bowel with a mesenteric defect. So type 2, you still don't have the mesenteric defect, but you just have the cord structure. Type 3, you have a complete division with the mesenteric defect. Type 3B, or the apple peel type of anomaly, is basically it's foreshortened intestine, and the only thing that's feeding this intestine is really a segment of your superior mesenteric artery. One arcade is feeding this entire bowel. Type 3B and type 4 is basically multiple atresias. So not just one, multiple atresias. And they can be any type. You can have multiple type 2s, you can have a couple of type 3s in there, but if you have more than one atresia, it's a type 4. Type 3 and type 4 atresias, the biggest problem with those two is those kids are more prone to having short bowel syndrome and have difficulties with absorption because you've lost a lot of intestinal length, and you may have to resect multiple segments in a type 4. So these kids may have more issues with their nutritional support. Treatment: you always resect the bulbous tip, and you do a primary anastomosis. You can do a tapering enteroplasty and an anastomosis. Ostomies are acceptable. Anytime you see one atresia, don't stop and just hook those two ends up. Always check the rest of the intestine, because if you have one atresia, there's a chance you're going to have other atresias. These atresias, other than the duodenal atresias, the duodenal atresias are mainly caused from a problem with recannulization of the lumen. These atresias are actually caused from a vascular insult. So there can be multiple areas of the intestine that can be affected. And rule out cystic fibrosis if you can post-op. Going down the GI tract still is malrotations. So this is the most common reason why pediatricians are sued in the U.S. for missing malrotations. So, question: what's the diagnostic test of choice for evaluating a possible malrotation? Plain radiographs, ultrasound, upper GI, CT scan, or barium enema? All right, perfect. So about half of you. Good. Upper GI. The upper GI is the test of choice. Used to be that the barium enema people would do, but in about 15% of the cases, the cecum can be in a normal location and you could still have a malrotation. So the upper GI has become the gold standard. So embryology of this, the guts forms as a long continuous tube. About 6 to 8 weeks, it leaves the abdomen, grows outside the abdomen, and then comes back into the abdomen. When it comes back in about that 10-week period, it actually rotates 270 degrees in a counterclockwise fashion, and then it gets fixated. When it gets fixated, there's 2 points of fixation. One's at the ligament atreides and one's where the cecum is. The reason for that is that's where you can get the widest mesentery in the intestine, is if those 2 points are fixated. So the beginning of the small intestine and the end of the small intestine, so that midgut area is actually going to be the widest areas to fix it at those 2 points. So if it doesn't get fixed at those 2 points, that's when you run into a problem. Associated anomalies: diaphragmatic hernias, gastroschisis, falloseals. The reason why there's malrotation or non-rotation with these issues, these problems, is because the intestine actually grows and comes back in, but in a diaphragmatic hernia situation, it's in the chest, so it's not going to rotate normally. Gastroschisis and fallocele never gets back into the abdomen, so it's not going to rotate normally. Duodenal atresias are the next association that you can see with the malrotation. That's why it's important when you see a kid with a duodenal atresia, you're pretty sure it's duodenal atresia, you're not sitting on a malro. Clinical presentation: majority is less than 2 years of age, and almost 80% we usually pick up in the first month to 1 year of life. You'll see some abdominal distension, but that is rare. When you see abdominal distension in these kids are very far down their clinical path. They probably had a volvulus, and these are not gas-filled loops. These are mainly fluid-filled loops. Most of the kids with malrotation will have a scaphoid abdomen and have a proximal type of a picture of an obstruction, because the obstruction is going to occur somewhere around the ligament atreides. So it's going to be a proximal obstruction. They'll have a scaphoid abdomen and lots of bilicemesis. Upper GI is a gold standard. And like I said, the BE, the cecum was normal in about 15% of the cases. Abnormal x-rays, you may see abdominal distension out of proportion to air. The other thing you can see in abdominal x-rays is you can see most of the intestine on a plain film will kind of look like it's on the right side of the abdomen. Usually when you think about a regular KUB, you'll see the colon coming around as an upside down U at the top, and you'll see the intestines in the middle of that. This one, you'll see the intestine more to the right than in the center. This is a couple of pictures of malrotation. This is malrotation with no volvulus, and as you can see, contrast does go down into the intestine. It never crosses over to the left side, so it never crosses over midline. It stays on the right side. This is a volvulus, so you see that the stomach is a little dilated, more so than this picture. The duodenal bulb is dilated, and you're coming to a bird's beak type of a situation where this is where the twist is occurring. So you don't see, and this is similar to if you did an upper GI for duodenal atresia because you were concerned. If you saw a picture like this on a duodenal atresia upper GI, you'd be concerned with malrotation and a volvulus. So malrotation without a volvulus on this side, malrotation with a volvulus on this side. How do you treat it? You'll do a LADS procedure. Basically, some pediatric surgeons think this is maybe a sham operation because what you're trying to do is you'll untwist, if there's a volvulus, it's a good operation. You untwist a volvulus and you do it in a counterclockwise fashion. You divide the bands, so there's some mesenteric bands and there's some peritoneal type bands that go from the cecum across to the small intestine. You'll divide those. You'll do an appendectomy on these patients because once you put the intestine back into place, you can't put it back in a normal rotation since it was never formed that way. So the entire colon is going to be on the left side of the abdomen. The small bowel is going to stay on the right side of the abdomen. The cecum is going to end up in the left upper quadrant, so your appendix is going to be in the left upper quadrant. So you'll do the appendectomy to avoid the problem with the diagnosis in the future. And you rule out any atresias on this as you do it. The reason why some people think it was a sham operation is really what you're trying to do is make as many adhesions as possible so it sticks. So that way the bowel doesn't twist anymore. So as long as you've divided it and it can stay in place, then your chance of recurrence is going to be much lower. Pictures of it. This is a twist here. This is untwisted, and then when you divide and try to open up this mesenteric folds, you can get as much of a wide mesentery as possible. Meconium ileus. This is with the cystic fibrosis patients. This is another distal small bowel obstruction, so you'll get abdominal distension as well as bilious emesis. Cystic fibrosis gene frequency is CF is about 1 in 20 for carriers. It's an autosomal recessive, so both mom and dad have to have this to get a patient that actually has cystic fibrosis. 6 to 20% of the patients will present with meconium ileus. So it's the main GI presentation for cystic fibrosis. Pathogenesis, the CFTR gene is a regulatory. It's basically a membrane-bound protein, controls the quantity and quality of the epithelial fluids. So alterations in this actually alter anything with the sodium contents and with the thickness and the viscosity of the fluid. So it affects the lungs as well as the GI tract. Family history of CF is important. Abdominal distension and bilious emesis. So distal obstruction. So this will basically present the same as a jejunal ileal atresia or Hirschsprung's disease or any of those things. Differential. Any distal obstruction would be a differential for this. So Hirschsprung's disease, small left colon, colonic atresia, which is rare, jejunal ileal atresia. Plain radiographs is obstruction without air fluid levels. There are no air fluid levels in this. So if you did your laterals or uprights, you won't see that. Soap bubbles or calcifications in the right lower quadrant, that's where the meconium is all sitting, is right at the cecum terminal ileum. You can treat this with a gastrographin enema, and what you'll do is you'll see a small colon and you'll get some meconium pellets out. And then when the kid is a little bit older, you can do a sweat chloride test to confirm the diagnosis. Well, for treatment, the gastrograph and enemas are both therapeutic and diagnostic. So you'll continue to do the enemas if you're getting results and if the distension improves. If you fail that, then like 62% it's successful. So if you fail it or if you perforate, then you end up doing the operation. There's multiple operations described in the literature. Typically at this point, what we end up doing is double-barreled ostomy, so we can do the washout. Sometimes if we can wash everything out and we can clear out the meconium, we'll close the ostomy at the same time and just put everything back in. Other times, if we think we're going to require more clean-outs, we'll leave the stoma in until we are satisfied that the patient's doing better. Sweat special considerations, definitely get a sweat test on these patients. You'll have to give them digested formula, pancreatic enzymes, and you have to give them fat-soluble vitamins. Hirschsprung's disease. So what's the best diagnostic test to determine whether a child has Hirschsprung's disease? Upper GI, ultrasound, anal rectal manometry, barium enema, or rectal biopsy. Correct, rectal biopsy. Manometry can give you an idea of Hirschsprung's disease. Barium enema used to be the test that you would do to try to diagnose it, but the rectal biopsy is gold standard. Etiology of this is the congenital absence of ganglion cells, and it's a mutation of the RET proto-oncogene. So ganglion cells basically travel from esophagus down to your anus, so at some point, wherever they stop migrating, that's where your level of Hirschsprung's disease is going to be. There are no ganglion cells in any area of the affected bowel, and when you stain this, the acetylcholinesterase stain is positive for this. So basically, pathophysiology for Hirschsprung's is aganglionosis equals no peristalsis, and no peristalsis is going to equal the obstruction. Rectosigmoid is the most common. About 80% is going to be in the rectosigmoid. You can have long segments, which extend further proximally in the colon, and that's about 10 to 20%. And you can have total colonic that actually extends into the small intestine in about 5 to 10%. The migration of these neural crest cells are about 6 to 12 weeks of gestation. There's two locations, the submucosal plexus, which is Meissner's, and the intramuscular plexus, which is Auerbach's. When we do a suction rectal biopsy, we're just getting the submucosal to make the diagnosis. Heredity, 30% do have a family history. Long segment has a stronger family history. Brothers of affected sisters are more at risk. So it's a sex-modified X-linked inheritance pattern. So it's carried with the girls. Clinical presentation. So most full-born babies pass meconium within 48 hours of birth. So 99 pass meconium within 48 hours of birth. So if you go 48 hours and you haven't passed meconium, that's when people start looking and trying to figure out what's going on with these kids. It's constipation. You can see some abdominal distension. In very delayed cases, which we see very rarely, are failure to thrive. You may have paradoxical diarrhea if it's long segment disease. They don't soil. So when these patients come in at 2 years old and they're complaining of constipation, you do a rectal exam or you ask the mom, hey, are they having problems? Do they leak into their diapers or underwear? They're like, no, they never leak. And when you do your exam, you don't feel any stool in the rectal vault. So the stool never makes it down to the rectum. 10% will have Down syndrome. Physical examination. In the older kids, you can feel a palpable fecaloma. When you do a rectal exam, it's an empty rectum. However, when you dilate with your finger and pull it out, you may have a huge projectile amount of stool coming out. Associations, you can have some hydronephrosis or hydroureters, usually due to the obstruction of the colon. There's urinary retention. Trisomy 21, like I said, is in 10%. You can also have trisomy 18. And you can have some congenital deafness, can also be associated, but rare association. The other neurocristopathies are MEN 2A, Waardenburg syndrome, and von Recklinghausen disease. Incidence is fairly common, 1 in 5,000. No real racial predilection. Male to female ratio is 4 to 1 for overall Hirschsprung's. So spontaneous Hirschsprung's or idiopathic is 4-to-1 male. However, for long segment, it drops down 1-to-1. So females are actually more affected with long segment. Risk of Hirschsprung's in siblings of affected females is 1 in 14. If you're a male and have a sibling, it's only 1 in 38. Barium enema, the rectum is supposed to be larger than the sigmoid in normal cases. So if the rectal diameter is less than the sigmoid, then it's suspicious for Hirschsprung's disease. Anal manometry, people have done to look at the sphincters and see if they relax, but the biopsy is the gold standard. You must have submucosa, must not show any ganglion cells, and when you stain this, acetylcholinesterase stain is positive. And you may also see hypertrophic nerves on the biopsy as well. This is a plain film of a patient that could have just basically a bowel obstruction. That's all it looks like on plain films. When you do the enema, you see that there's a long segment here where the rectum, so if I flip this picture upside down, that would have been a normal BE. This one is the abnormal BE, so it's a 2-to-1 change of the, it's a 2-to-1 change caliber between, at least a 2-to-1 change between the sigmoid and the rectum. Treatment, just relieve the obstruction. You can medically manage these with frequent enemas, and if they do well with that, you can do a primary pull-through procedure at a later date. Some people are doing neonatal pull-through procedures right away, which is also another way to do this. Or the third way that's been described, that's a conservative way, is if you can do a leveling colostomy. We'll do this if they failed medical management. So a leveling colostomy is basically you'll go in. You can do this laparoscopically. Typically, we'll do it laparoscopically. We'll do multiple biopsies along the colon to find the level at which you find ganglion cells. So multiple frozen sections until you find the ganglion cells. You'll bring that out as a stoma. And then that stays out, and then you can go back in and do a pull-through procedure at a later date. Ultra-short segment Hirschsprung's disease, very rare, but just doing a myectomy at this point may actually resolve that problem. Types of pull-through procedures that you may see, there's only 3 types. The Swenson is basically you're removing the entire rectosigmoid, so you're doing, you're taking out the whole entire distal rectum, sigmoid, everything affected. Duhamel procedure is you're leaving a bit of the sigmoid in place that has no ganglion cells, and you're doing a side-to-side anastomosis of the small intestine or the colon that has ganglion cells with the sigmoid. Some people do these primarily. We usually do this if we have a long segment or actually really total colonic, where you have to go up into your ileum. You're concerned about water absorption, and instead of doing an anal anastomosis or a pouch, you can actually leave a portion of the sigmoid in and do a side-to-side so that you can get some water absorption with the Duhamel. The Suave procedure is the third, and this is probably the more common procedure people do. This one you actually do a mucosectomy, so you leave the rectal wall in place, and you actually do the mucosectomy and pull the ganglionated segment through the rectal wall after your mucosectomy, and then do your anal anastomosis. So the first one, you remove the whole thing. The last one, you're going to use that rectal wall, the muscle as a tube that you can track to. The benefit for doing that is you don't do a lot of dissection in the pelvis, so your pelvic nerves that innervate your bladder, erectile dysfunction, all of those type of things you're concerned with, you're staying within the rectal wall, so you don't have any of those problems. Imperforate anus. Incidence on imperforate anus is 1 in 1,500 to 1 in 5,000. Imperforate anus is one of the vactral anomalies that we're concerned with. So anytime you have one of those, you're going to look for the radial, limb, or the renal and the cardiac and all the other things. There's no race predilection. Embryology of this is the cloaca, which is your genitourinary tract, divides 4 to 6 weeks. The anterior part of this is going to be urinary, and the posterior part is going to be the colon. Vactral anomalies. The most common associated anomaly with the imperforate anus is a GU anomalies. The most common GU anomaly associated with it is really absence of the left kidney. So you'll have so most of these patients will get abdominal ultrasounds to look for that. Diagnosis and therapy, physical examination, which you'd be surprised at how many babies get out of the hospital without a physical exam. But if you look for an anus and find an anus, they have an anus. Observation for 24 hours. If they haven't stooled, sometimes they can have a small fistula there. So if they haven't stooled, you watch them for 24 hours and see if they stool. Re-examine the perineum for that fistula. If they've never stooled and they definitely have an imperfect anus, you can check the urine for meconium. That'll tell you they'll give you an idea if it's a high fistula or not. Plain x-rays will show an obstruction. Treatment, if it's a high lesion, which is usually above the levators, you do a diverting colostomy, and you can do a posterior sagittal anorectoplasty at a later date. Low lesions, you could probably do a primary anastomosis, and the low lesions are you have either a perineal fistula in boys, or you have a posterior fourchette or rectovaginal fistula in a girl. That's pretty much it for the perforates. Other problems, intussusceptions. Question for this one was a 6-month-old infant with intermittent abdominal pain and passage of heme-positive stools. What's the best initial test to confirm diagnosis? Plain radiographs, barium enema, ultrasound, an air contrast enema, or an upper GI. Barium enema. Okay, we'll talk about it. Ultrasound is probably the most common test we use. This is the question is the initial test. So if the first test that we're going to do for these kids is we're going to look at the ultrasound to see if we see the intussusception, the barium enema in case that's not effective, or in case we do find an intussusception would be the next thing we would do to reduce it. What's the definition of this? It's basically a telescopic invagination of the bowel, and that leads to a bowel obstruction. The incidence is 1 in 300 to 1 in 1,000. Male to female ratio is fairly equal, 3 to 2. Seasonal peaks. We see this in the fall and spring when there's flu season, when they get gastroenteritis, when they start school. A lot of this may be more of a motility type issue. It's similar to we'll see peaks also with pyloric stenosis as well, seasonal peaks. But this is when you see hypermotility of the intestine, and that may cause the actual intussusception. The age for this is usually somewhere between 6 months and 2 years of age. So that's your most common age that you're going to see this in. Etiology is usually idiopathic. Lead points, we only see lead points in less than 5%. A lead point is that point that's causing the intussusception, so it's less than 5%. If you see a 10-year-old or 12-year-old with an intussusception, you may be a little bit more concerned with the lead point. And these lead points can be either a Meckel's diverticulum, a polyp, lymphoma. Sometimes they've had appendicitis in the past that was undiagnosed, and that appendix can have a scar tissue that can also be a lead point. Usually less than 2 years of age, and it's usually between 6 months and 2 years of age. Recurrence of distress with intervening periods of wellness. So these are the kids that are playing around, and then suddenly they draw their legs up, they scream, they're inconsolable, and then after a while they are back to normal again. This is because what they're feeling is basically you're feeling peristalsis against an obstruction. So every time a peristaltic wave comes in, they have severe pain. Once it passes, they feel okay again. You can have vomiting. It's usually non-bilious initially. If it's later on in the course, it can be bilious. Bloody diarrhea, and you may be able to feel abdominal mass. This whole current jelly stool, yes, you can see current jelly stool. If you ask any medical student what current jelly is, no one knows, so they don't know the idea of what it looks like. So if they're heme positive, and they've had this type of an episodes where they're well and they're in severe pain and they're well again, that's probably the most sensitive way of thinking about this. Ilio-ileal intussusceptions we see in the post-operative period, so that's a whole different animal. So a lot of times after an operation, you may see an ilio-ileal that can cause obstruction. Sometimes those actually, most of those will resolve on their own. Ileocolonic is the most common. This is the one that we're talking about. And sometimes you can have a colocolonic. This is the target sign, which is what you see on the ultrasound. So it's bowel within the bowel, and that's a target sign. So that's what you're looking for. If you see this, or if you're still concerned with intussusception and you don't have a good ultrasonographer, you can go to a barium enema or an air contrast enema, either one. And if you do the barium enema, usually people, if they don't have a diagnosis, they'll do the barium enema. If they have a diagnosis and they know they're going to go for reduction, then they'll either do an air contrast or a barium enema for the reduction. On this picture, you can see the intussusception is right here, and the contrast is coming in. A couple of things about reductions of this. You want to reduce it, so you're going to try to reflux it through the ileocecal valve. So you want to see some contrast reflux through that to make sure it's completely reduced. The number of times you can reduce these things are, you can take them down 3 or 4 times for repeat enemas to try to get this done. If you go beyond that, most likely they'll probably call us and complain bitterly, and we'll take them to the operating room. But a lot of places, children's hospitals, they'll do this 5, 6 times and get it down and get it reduced. The enema reduction is only 85% effective, so we always tell families within that 24-hour period to look for recurrences. And then when we do the operation, you can do this laparoscopically or open. We used to always say that do the appendectomy with this. 2 reasons. One is the appendix could be a lead point, one. Second thing is we always used to make the right lower quadrant incision, and when you have a right lower quadrant incision, everyone assumes your appendix is out. So we would do the appendectomy. Now with laparoscopic surgery, everybody comes in with 3 holes. No one knows what's going on. So if your appendix is there or not, no one knows. So a lot of the people that are doing these laparoscopically are foregoing the appendectomy at these. So, but on the boards, this is a typical operation, is you do the operative reduction and you do the appendectomy. Meckles, fairly common. 2% of the population has it. Asymptomatic patients, usually male is equal to female. Symptomatic patients, males are actually 3 to 4 times more common than females. Etiology is basically the persistence of the omphallomesenteric duct. Bleeding, you really get bleeding or you get obstruction. Those are the 2 real clinical scenarios that we come in contact with. Bleeding is due to ectopic gastric mucosa, and the gastric mucosa actually will be secreting, is an acid secretor. It'll actually eat through the mucosa at the base of the Meckles, so the bleeding is going to occur where the ulcerations are at the base. The obstructions are basically because the Meckles can either get attached to other areas of the bowel, or there can be a continued Meckles that actually is still attached to the base of the umbilicus. So it goes across the abdomen, and that can actually cause either volvulus or twist, or it can cause an intussusception if it's a lead point if it's a lead point. Painless rectal bleeding in the adolescents, 40% will have a Meckles, or that's the 40% of the presentation will be painless rectal bleeding. Umbilical discharge, you usually see this when they're younger. Obstruction at about 30%. So kids that have never had an operation before and suddenly come in with a high-grade obstruction and have never had surgery, don't have any hernias, you'd be concerned with maybe a persistent omphallomesenteric duct. And you can have infection or diverticulitis in these patients in about 20%. Diagnosis, if it's a lower GI bleed, we do a technetium scan. If there's a little opening at the umbilicus, you can do a fistulogram and see where it goes. So if you have a little opening in the umbilicus and it's draining fluid, if it's bilious fluid, it's most likely maybe a Meckles. If it's clear fluid, it may be a urachal remnant that's attached to the bladder. So you can actually diagnose that from doing the fistulogram. The obstruction, you just explore those patients. Bleeding, you resect and you can look for the ulcer. Typically now we'll do these laparoscopically and you staple across the base of that Meckles. So you staple across the base of the Meckles and you usually take the ulcer with you. Fistula tracts, you resect the tract, and obstruction, you resect the Meckles. People say, what do you do with you find a Meckles incidentally, and do you do anything with it? Most of us don't do anything with those that you find incidentally. Okay, we're going to switch topics a little bit out of the GI tract. We'll talk about a few of the pediatric tumors. The two main types, really, neuroblastoma and Wilms. So we'll talk about neuroblastoma first. This is the most common extracranial solid tumor of childhood. It's about 8% of childhood tumors. The neuroblasts are the culprits, or where this forms from. Really, things to remember about neuroblastoma is bad parts of neuroblastoma, endemic amplification. You see that in 25% of the cases on this tumor. This is a bad actor for this. Hyperploidy is the second thing that you could remember. The DNA index, usually hyperploidy is bad in most tumors. Actually, in neuroblastoma, it's a good thing. So hyperploidy is a good thing. Third thing to remember is really this is based on the age and the stage of the patient. The younger the patient is, the better the outcome is. Anatomy, most of the time, 40%, it's the adrenal glands that are the culprit. 25% of times you can get paraspinous, and 15% of the time you get thoracic. Bad things to look for also, if the markers, the ferritin, LDH, and neuron-specific enolase, those are all negative points about the tumor. If those are elevated, it's a bad thing. Survival for this, the younger you are, the better your survival. 83% of the patients survive if they're under 5. But when you get over 5, or 83% of the infants survive. If you get over 5 years old, only 40%. The last thing you have to remember is probably the stage 4S. This is actually looks like metastatic neuroblastoma. All the patients are under a year of age. It's metastatic, but there's no bone involvement, and it's a very good prognosis even with no surgery. So that's actually a good prognosis. Symptoms based on the location. So if it's you can have abdominal masses, neurological issues, fractures if they occur in the spinal column, opsoclonus myoclonus, which is due to an antibody that's against the tumor proteins, and that's the dancing feet type of a patient where their legs move intermittently. I think that's it with neuroblastoma. We'll switch over to Wilms. Wilms is the most common childhood abdominal malignancy. So the other one was the most common solid. This one's the most common abdominal malignancy. Again, it's about 6 to 7% of the tumors. The most common tumor that we see in kids is really, other than ALL and the most common solid tumors are usually brain tumors is what we see in kids. Survival for Wilms tumor is greater than 90%, so it's much more different than the neuroblastoma. This is a very good tumor to have if you had to have one, and 90+% is in all stages too. Asymptomatic abdominal masses, you can get UTIs, you can have varicoceles, hematuria. There's two genes that we look at, the WT1 and with the WT1 gene, which is you can have the alterations in 11p13 and 11p15. The 11p15, the Beckwith-Wiedemann, is actually probably something to remember. That's that you can have other abdominal tumors such as hepatoblastomas. You can have macroglossia and other things going on with that. 90% is favorable with favorable histology. 3 to 7% can be anaplastic. Clear cell sarcoma of the kidney is probably the most common. Clear cell and rhabdoid are two of the other tumors of the kidney that we see in kids. Differences between this and Wilms is bone metastasis is very common in the clear cell, and in the rhabdoid, 20% of these can have CNS tumors. The stages are similar to any of the other stages. Stage 1 is limited to the kidney all the way out to stage 4, which is distant spread. Stage 5 is bilateral disease. And even with this, when you take all stages, it's still about 90% survivability. The chemotherapy is very good. Surgery is the primary mode of treatment for this. We resect these when we see these right away. The only times we don't resect these straight up is if it's stage 4 disease. We'll treat with chemo and try to get the metastatic disease under control, and also stage 5 disease. If you're dealing with bilateral tumors, you're going to treat those initially with chemo. But the other stages, stage 1 through 3, we treat with surgery. Other congenital issues. Which statement is correct about gastroschisis? Infants have multiple congenital disorders. Most will suffer from malabsorption or short gut syndrome. 50% will have associated intestinal atresias, and most are small for gestational age. All right, it's a pretty fair mix here. Actually, it's D. Most are small for gestational age. They don't have multiple congenital disorders. Omphalocele are the ones that do, but the gastroschisis really don't. Malabsorption and short gut syndrome, usually not. The intestinal atresias, they do have intestinal atresias, but only 15 to 25% will have intestinal atresias, not 50%. Abdominal wall defects, this is the gastroschisis is one of them. Like I said, the intestinal atresia is about 15 to 20%. The umbilicus is there on these patients. The defect is to the right of the umbilicus. There is no covering over the intestine, so the intestine is exposed to amniotic fluid. So that's where you get very dilated. It's almost like a burn to the intestine. It's very dilated edematous bowel. There's no chromosomal anomalies associated with the gastroschisis. When you compare that to the omphalocele, you can have associated anomalies. There's chromosomal anomalies, cardiac anomalies, other things. A ruptured versus non-ruptured. Typically, when we see an omphalocele, they're non-ruptured. They have the amniotic sac intact. This is the middle picture. So the umbilicus comes down. The amniotic sac is attached to this. The liver can be up into the sac as well, but it's covered. The intestine is covered. And then in other cases, this is more of a ruptured omphalocele here, where the liver's out and the intestine's out. Pentralogy of Cantrell is one particular type that's the most severe that we see. You can have an omphalocele. You have a Morgagni hernia or central hernia of the diaphragm. You can have cardiac defect or cleft of a sternum. And you may have the absent pericardium, and you may see the heart may be exposed too. Congenital lung issues, the two things that they're going to ask you probably is differentiate between sequestrations and CCAMs. Both of these now are called CPAMs, congenital pulmonary malformations. So CPAM is the new terminology for that includes both of these. However, I don't know if the boards have changed or not yet. Sequestrations, big thing to remember, they're solid masses. There's a systemic artery supply, either coming from the celiac, aorta, but it's a systemic supply. There's no bronchial attachments to this. It's not attached to the lung, and surgical resection is what you do for these. CCAMs, the congenital cystic adenomatoid malformations, are basically cystic lesions. It's abnormal lung tissue. They are attached to the bronchus. They're part of the airway, and that's why they have an increased risk of infection, pneumonias, other things. And surgical resection is still the same, is what we do for these as well. So those are the differentiating factors between the congenital lung problems that we see. Diaphragmatic hernias, another topic. Real briefly, 1 in 2,500 births. Mortality is still fairly high, 40 to 60%. Most common one we see is the Bactolac hernia. It's and 85% of this is left-sided. Morgagnis are rare. It's maybe 15% of the cases we see. Chromosomal anomalies in about 30%. The biggest problem with diaphragmatic hernias is pulmonary hypoplasia and pulmonary hypertension because of this. That's what kills the kids. That's what we always have to deal with. The surgery for this, you either repair these primarily or you can do a patch repair if it's a large defect. But the real problem with these kids is the ventilation issues. So we have to use nitric oxide. We have to use multiple ventilation maneuvers. And if that fails, they go to ECMO. So they go to extracorporeal membrane oxygenation. So we put them on bypass. And that's basically ped surgery in a nutshell. I'll take questions on anything if you guys have any. Yes, sir. So the asymptomatic adults, So how did you diagnose it? So a lot of times they'll be looking for either appendicitis or they have abdominal pain of unknown etiology, and you find it. The thing that I always preach is that if you find a malrotation, and if the patient's having symptoms that aren't diagnosed by any other issue, then fixing the malrotation is probably the proper way of going. The older you get, the volvulus risk is lower, but there's still a risk of volvulus. When you get to the older patients with malrotations, the other thing you see is they get a lot of malabsorption problems, and they have a lot of other issues. They have pain with eating, they have malabsorption problems, so they have other issues associated with it. So I always say that if you don't find another source for their symptoms, then you repair the malrotation, because they still have a risk of volvulus even then. You just have to tell them that you have a malrotation, and if they don't want to have surgery or if they're completely asymptomatic, they just have to understand that there's a risk of volvulus with them.